primary angle closure, a very common form of glaucoma. And what we're talking about is primary pupillary block angle closure, and a few words about nanophthalmos, which is fairly rare, but a form of angle closure glaucoma. So pupillary block angle closure is caused by the iris coming forward to lie over the trabecular meshwork. And this can cause an abrupt elevation of the intraocular pressure, so-called acute angle closure. But it can also cause intermittent problems with the intraocular pressure or even chronic pressure elevation that is not distinguishable from primary open-angle glaucoma. It's felt that a relative seal forms between the iris and the lens, trapping the aqueous behind the iris and driving the iris forward to cover the trabecular meshwork. There's a lot of research going on trying to understand the mechanism of angle closure, and just to let you know that we're not 100% sure what's going on. Some work by Harry Quigley and his colleagues suggests that the mechanism may be due to changes in iris volume and choroidal thickness, and that while most irises lose volume during dilation, those prone to angle closure do not. So this is an area of some flux, but right now we consider it to be a block that occurs at the pupil, causes the iris to drive forward, and that covers the trabecular meshwork. In primary open-angle glaucoma, I use the kitchen sink analogy. So in open-angle glaucoma, the pressure is elevated. You look at the sink drain, or in our case, the trabecular meshwork, and it looks normal, but we know that there's something wrong deep inside. The difference in angle closure glaucoma is that we can see that the trabecular meshwork is covered by the iris. So that's sort of like having the stopper in the sink, as we see here on the right. If we think about the people who are most likely to develop this, it definitely has a racial component in that it's much more prevalent in people of Asian derivation. Rather startling number that 91% of bilateral blindness in China is due to angle closure glaucoma. And also people who are of Asian heritage respond less well than Caucasians to laser iridotomy for reasons that aren't clear. In the U.S., Inuits and other Eskimo groups have a high prevalence of angle closure. They are ethnically very Asian. It's uncommon to have acute angle closure glaucoma among people of African heritage, but chronic angle closure is more common in that population group. People who develop pupillary block angle closure are usually hyperopic. They have a small eye, sort of a crowded eye, often a shallow anterior chamber. It doesn't typically happen in teenagers. It tends to happen as people get older, because as we get older, our lens thickens and our pupil becomes smaller, and both of those serve to increase the pupillary block. Women are at substantially increased risk when compared to men, and people who have a family history of angle closure are also at increased risk. Things that tend to dilate the pupil can precipitate an attack of angle closure, such as dim illumination, emotional stress, mydriasis. So this is where all those warning labels come from that say, do not use this drug if you have glaucoma. And that's on all sorts of cold medicines and sleep medicines. For me, it's important to tell my glaucoma patients that they can use these medicines without concern. If their angles are so narrow that I'm worried that they're going to go into an attack of angle closure by going into a dark movie theater or taking a cold medication, then I would do an iridotomy. And certainly primary open-angle glaucoma patients are not at risk for any of these medications. The other thing to recognize about mydriasis is that it does not happen during full dilation. It tends to happen as the iris is slowly coming down. So if we're seeing a patient in the clinic and we are wondering if they're at risk, we go ahead and dilate them and their pressure is normal dilated. That shouldn't give one a tremendous sense of relief, because when the patient's in the car driving home and the pupil comes down slowly would be the time that they would go into this attack. Conversely, if you use very strong cholinergic agents, high percentage pilocarpine or things like ecothiopate, you can move the lens iris diaphragm forward, make the pupil very small, and cause angle closure. There are three forms. I'm going to go through each individually because it's otherwise doesn't make a lot of sense. So we're going to talk about acute angle closure. That's what we're all thinking about when we talk about this. But one can also have intermittent or subacute angle closure and chronic angle closure. So acute is the stuff that comes into the emergency room in the middle of the night. People who have severe pain, headache, blurred vision, colored halos around the lights. They can be in so much distress that they have nausea and vomiting, and sometimes are even mistakenly considered to have a GI problem. We'll just go through a case here. A 49-year-old white man presents with acute loss of vision and pain in his right eye. And he has a 4-day history of intermittent right-sided headache and pain with blurry vision that has gradually gotten worse. On the day of presentation, the pain is constant, the headache is severe, he feels nauseated. He has no history of trauma in that eye. So this is his picture. You can see that his pupil is mid-dilated, his cornea is steamy, his eye is injected. So in my clinic, if a resident comes up to me and says, this is the history, I would always ask two questions. So what two questions? One would be, what's the patient's refractive error? If this patient's a -4 myopic individual, the diagnosis of pupillary block angle closure is pretty remote. And then what does the other angle look like? If the patient's phakic in both eyes, we're clearly not going to get a good gonioscopy view in this eye. But if the other angle is wide open, then again I'm questioning the pupillary block angle closure diagnosis. So these are his numbers. He's count fingers in this right eye, intraocular pressure of 15 millimeters of mercury, and he is a hyperopic individual. So what do we see in acute angle closure glaucoma? The eye is injected, the cornea is cloudy, pupil is mid-dilated and fixed. Very high intraocular pressures can be 60 or higher, and iris Bombay. So this is iris Bombay. You can see that the peripheral angle is very narrow, peripheral anterior chamber is very narrow. The iris is bowed forward, as you can see here. You can just imagine that it's being pushed forward by the aqueous. And a view on gonioscopy of Bombay. Sometimes these attacks will break spontaneously, and the patient will present with flare, cell, and transient hypotony, and that can make the diagnosis very challenging. And later, one can see lots of sequelae to let you know that this patient had an attack of angle closure. When the pressures get this high, it causes significant changes to the anterior segment. Iris atrophy, Glaucomflecken, which I'll show you in a second here, peripheral anterior synechia. One can have pigment deposition on the iris and cornea, and then after the attack is broken, disc hyperemia, and later disc pallor and cupping. So these are patients who have had attacks of angle closure. This person on the left has had a trabeculectomy with a rather large iridectomy, but you can see these areas of iris atrophy. And on the right, you see this spiraling, which is interesting and seen in patients who've had attacks of angle closure. I always think of it as though you had a bicycle and someone took the spokes and twisted them. So the fibers, instead of being radial, are actually twisted. Another patient with iris atrophy, you can see these areas are where attempted iridotomies were done, which is very challenging in somebody who has a mid-dilated pupil and corneal edema. And this is glaucom flecken. Glaucom flecken is from the stasis of aqueous in the anterior chamber, and you see these subepithelial deposits in the lens, which can actually marginate over time and clear some. Just another example of glaucom flecken here. It's beneath the anterior capsule. You can see some iris atrophy here as well. Intermittent or subacute pupillary block angle closure is a much more subtle disease. Patients can have intermittent eye pain and or headache. May be associated with blurred vision. Sometimes see colored halos around lights. This is a really interesting case of mine, a woman radiologist, so like ophthalmologist, she's working in the dark all the time. She's had a history of intractable headache that has gone on for years and has had a huge workup, including 2 MRIs, a CT, and even a lumbar puncture. Thankfully for her, she was seen in our neuro-ophthalmology clinic, and Dr. Lee did gonioscopy and found her to have critically narrow angles. We did an iridotomy, and she'd never had a headache again with 9 years of follow-up. So uncommon, but an important diagnosis to make. Often the only thing we see are occludable angles on gonioscopy. Patient with very narrow angles, you can see the trabecular meshwork only when I indent. Right there is the pigmented trabecular meshwork, but I let up on the pressure on the gonio lens, and the angle completely disappears. This is a patient also with intermittent angle closure. This looks like a trabecular meshwork, but the angle is very, very narrow. And when I use the corneal wedge, you can see that the wedge comes together right at the iris and behind that pigmented line. And when I indent, we can see that the trabecular meshwork is much farther back there. I'm having to push pretty hard to see the meshwork in this patient who has intermittent angle closure. In chronic angle closure, as I said earlier, sometimes seen more commonly in people of African heritage, the symptoms are just like primary open-angle glaucoma. There really are no symptoms until late in the disease, when people have a gradual decrease in peripheral and night vision, and then late loss of central vision. And on exam, elevated intraocular pressure, which can lead to optic nerve head cupping and visual field loss. And really the only thing that's differentiating this from primary open-angle glaucoma are very narrow angles on gonioscopy and often extensive peripheral anterior synechia. Well, a lot of things on a differential diagnosis of angle closure glaucoma, and some of these really have pupillary block. Plateau iris often has an element of pupillary block, as does phacomorphic and nanophthalmos, which we'll talk about here in a second. In aqueous misdirection and ciliary body swelling, the center part of the angle is often more shallow than it is in pupillary block. And similarly with tumors. But the pupillary block typically has this bulging iris, the Bombay, where the central chamber is a little bit deeper than the peripheral chamber. Laser iridotomy, or rarely surgical iridectomy, is a treatment to break the pupillary block. So a little cartoon of pupillary block. You can see the iris is forward, covering the trabecular meshwork. We make an iridotomy by making a hole in the iris, and allowing the aqueous to come through lets the iris settle back into a more normal position. Laser iridotomy here, I prefer them temporally, but some people prefer to do them superiorly. It's important to recognize that when you do an iridotomy, the angles should be deeper. We hope they'll be deeper, but they are rarely deep. They're rarely normally deep like you would see in a myopic or emmetropic individual. This is somebody with the Van Herrick test looking at someone with very narrow angles, just a little whisper of aqueous between the corneal endothelium and the iris. Iridotomy is performed, and afterwards you can see that the chamber is much deeper, but it's certainly not deep. And when we do an iridotomy, we really need to follow these people with serial gonioscopy. If you have an attack of glaucoma, pressure of 60, we treat them with pretty much all the drops. We're a little bit desperate. We usually hold cholinergics like pilocarpine until the pressure is low enough that it can act on the iris. Otherwise, it doesn't do anything. Use systemic carbonic anhydrase inhibitors like acetazolamide, and one can use hyperosmotic agents like mannitol. One can break an attack of pupillary block angle closure with corneal indentation by pushing on the cornea and driving the iris back. I'm going to do the same thing with a tonometer tip. This is just a drawing showing the small lens, a Zeiss or Posner or Sussman lens, pushing in. You can see the folds in the cornea and how that drives the iris back. So we use that diagnostically to look at the angle, as we did in the movie I showed you a few seconds ago, but one can also use it to break an acute attack. And lastly, surgical iridotomy, if the view is clear enough. One can do a surgical iridectomy, but that's pretty uncommon. If the view is inadequate to do an iridotomy, one can do an iridoplasty through a cloudy cornea to try to pull the iris out of the iridocorneal angle. And if that is done, and if the attack does break, then still an iridotomy does need to be performed. Again, surgical iridectomy is rarely done. The few that I've done as a standalone procedure have been in patients who are unable to cooperate, people who are mentally challenged and can't sit at the laser to have an iridotomy performed. If this is after an attack of glaucoma and I'm taking him to the operating room for an uncontrolled intraocular pressure, I would probably do a trabeculectomy, because I'm not sure that if I do a surgical iridectomy, the angle will open adequately, and I certainly hate to take the patient back to the operating room twice. One can do goniosynechialysis to break synechia, and this is where one uses a spatula or forceps to physically pull the iris out of the iridocorneal angle and break synechia if they are, and I have in quotes here, fresh, less than a year old. This is usually done at the time of cataract surgery, and I have done very little goniosynechialysis. I've been relatively unimpressed that it helps very much, but there are some people who have had good success with it. And sometimes the angle is just damaged beyond repair. The patients need surgery, often trabeculectomy, but remember that these people are the ones who go on to develop aqueous misdirection. So I'm always very concerned to do a trabeculectomy on somebody who's had an attack of angle closure, and I would use long-term atropine postoperatively to try to prevent that. Don't forget the fellow eye. So the untreated fellow eye, if it's also phakic, has a very high chance of developing angle closure over the next few years, and sometimes just the anxiety of having an attack of angle closure in one eye can trigger the attack in the other eye because of sympathetic stimulation. So you should always, whenever you have the opportunity and the mayhem that sometimes goes along with an attack of angle closure, think of the other eye and do a prophylactic iridotomy. In the section on iridotomy, we talk about indications. You would do an iridotomy of somebody who has elevated pressure with appositional angle closure or more than 180 degrees of apposition. I would do it if I saw synechia. Sometimes you can see, especially in the superior angle, segmental pigmentation from recurrent contact of the iris against the trabecular meshwork. As I just said, if there's an attack of angle closure in the fellow eye, or if you've done an iridotomy in the fellow eye, are all reasons to consider doing a prophylactic iridotomy. And again, do gonioscopy after the iridotomy. Some of these patients have plateau iris syndrome. As the lens of the eye gets bigger, they can develop a phacomorphic component. And sometimes the angle just does not open adequately, and the patient then needs biometry and perhaps a lens extraction. One thing that drives me crazy is physicians who recommend to their patients that they avoid dark movie theaters and avoid cold medications because their angles are critically narrow and at risk for an attack. I don't think any patient deserves to be worried that much about angle closure. And I think if you have a patient that you're going to put on notice that they're at high risk for angle closure, you should just go ahead and do the iridotomy. It's not a very high-risk procedure. There's a term mixed mechanism glaucoma, meaning that the patient either had narrow angles and despite adequate iridotomy and treatment for angle closure and open angles continues to have elevated intraocular pressure. One can also have mixed mechanism glaucoma in somebody who starts off with open angle glaucoma but whose angles narrow over time, either because their lens enlarges, which happens in all of us, or they develop exfoliation and the lens becomes loose, or because they're on cholinergics like pilocarpine. So the key points: primary pupillary block angle closure is a common form of glaucoma. It's a leading cause of blindness in some Asian countries, particularly China, but other countries as well. It develops in hyperopic eyes, and it is treated with an iridotomy. Just a special case of angle closure we'll talk about for a minute here is nanophthalmos. This is a small eye that is structurally mostly normal. So it's separated from microphthalmos, and the microphthalmos are often deranged eyes that are structurally abnormal. It's not 100% accurate to say that these eyes are structurally normal because they have very thick impermeable sclera and a very large lens for the size of the eye, but they're not disorganized. So by definition, a short eye, there's nothing magic at 20 millimeters of axial eye length, but the shorter the eye, the greater the risk of nanophthalmos. Not a very pictorial disease, but you can see that this young lady has very small eyes, and this is her sister with a very high plus lenses. They develop angle closure at an early age. They have thick and impermeable sclera, meaning that as fluid gets in the suprachoroidal space, it cannot get through the sclera, and so they have a very high risk of choroidal effusion, particularly if they have any kind of surgery performed. It can be inherited in a dominant fashion. You really don't want to operate on these eyes if you can help it. So if you see somebody with nanophthalmos, should make sure that you do gonioscopy. If the angles are narrow, which they probably are, do early iridotomy and perhaps even iridoplasty, trying to avoid having to do intraocular surgery. If one does need to do intraocular surgery, we would usually do scleral windows, making cut down in the inferior sclera to allow drainage of choroidal fluid that might accumulate after the intraocular surgery. So angle closure glaucoma, definitely something that you will see in your career. Important to know how to manage it. It's also important to think about things like intermittent angle closure in people with unrelenting headaches. Also important to recognize nanophthalmos and know that you should avoid, if possible, operating on these people. So if you're technician tells you that you have to special order a super high plus lens for a patient, it should make you wonder and check their axial eye length, make sure they don't have nanophthalmos.